Okay, so hi everyone. So yesterday we had introduced respiratory physiology to you. We looked at some basics of the anatomy, basic gas laws, and then we got into the first step of respiration, which was ventilation. And we looked at how ventilation occurs, what is the anatomical basis for that. And then secondly, we also looked at the mechanisms, and we started looking at the volume changes. And you should familiarize yourself thoroughly with that diagram, which shows the various volume changes that are expected in the when one breathes, and how it relates to the total volume of the lungs. Because not only are these the measure of normality, we use this to, in fact, assess abnormality. And later on, today we will mention some of those tests that are done. After looking at those volumes, we started discussing dead space. So dead space, I told you, and so we can just quickly recap. It's the portion of the air that does not participate in gaseous exchange. And it's divided into two: the anatomical dead space, which does not have alveoli. And this measures about 150 mils. And it is the one that goes from the nose right to the respiratory bronchiole. So all this is dead space, anatomical dead space. But we said that actually anatomical dead space is not the only dead space. There's what we call the total dead space, or also known as physiological dead space, which is equal to anatomical dead space plus alveolar dead space. Now, what is alveolar dead space? Alveolar dead space is that space which, that volume of air which is in contact with the alveoli but does not participate in exchange. And why should that be? That would happen if either the alveoli are inflamed or edematous. They may have fluid in them, pulmonary, edema. They may have the vascular flow may not be adequate. So there are other factors, and all of those are pathophysiological factors. In a normal person, we expect the alveolar dead space to be close to zero. So in health, physiological dead space and anatomical dead space are equal. They're not synonymous, they are equal. What is synonymous is total dead space and physiological dead space. Yeah, you could use either one of them. Physiological sounds better. So I think that's where we left it. Yeah, we looked at this diagram, which I don't think I need to go over again. But what we said was with each breath, we add 350 mils to the air that is in contact with the alveoli. Yesterday we said that the air that is in constant has the potential of being in contact with the alveoli is it's approximately 2.2 liters, and it is into this tank of so-called alveolar air that with each breath we introduce 350 mils of fresh air from the atmosphere. 150 remains in the anatomical dead space. And then when we breathe out the stale air, and then the stale air fills up the anatomical dead space, so that the next breath you take, it is the stale air which is pushed inside. So you only get fresh. The only fresh air that you get is 350 mils. If you think about this little cycle using this diagram, you will understand it more. The conclusion is that we can only get with each breath that which is in excess of anatomical dead space. So why does dead space matter? What's the issue? It matters because, first of all, it means there is some what we call wasted ventilation. Yeah. It's also very important when we, for example, put people under anesthesia. When you put someone under anesthesia, you put a tube and you collect this tube via a longer tube to a machine that supplies the gases, anesthetic gases and oxygen. So that tubes become an extension of the airway. So now the person has a longer dead space, meaning you have to adjust the tidal volume by that longer space to provide enough effective ventilation. The same, theoretical consideration one can have that if you go underwater, can you breathe through a tube? Now, of course, you can breathe through a tube, but there's a limit. If that limit, if the volume of the tube becomes very high, you remember our vital capacity is 4 liters or so, 4.2 liters. So if you keep on going underwater with a longer and longer tube, once the volume reaches 4.2 liters, you will not be able to get any fresh air. You'll only be breathing what is in the tube. So that has its limits. That's why without a pump, you cannot breathe underwater with a long tube. That's why you have to take compressed air, or you have to have air which is pumped through long tubes, fresh air coming in and stale air going out. So that's the question. What's the absolute upper limit? For the absolute upper limit for the length volume of the tube, the volume would have to be, absolute limit would be vital capacity. But can you imagine going underneath and trying to breathe with your full vital capacity for each breath? So practically speaking, you cannot do that. The other side of dead space is sometimes we have to reduce the dead space or to help a patient. There very sick patients, very ill patients sometimes don't have enough strength to breathe. Their pulmonary work has become too much for them because they have other metabolic illnesses, say. And they have to then be intubated and put on ventilators in the ICU. In those cases, people like myself or ENT surgeons are called to put a tracheostomy. Tracheostomy is basically an opening made into the trachea, and you bypass the upper respiratory tract, most of it. So you shorten the dead space, or not shorten, but lessen the dead space. And those people who couldn't breathe with their normal airway, given a shorter tracheostomy tube, can breathe, and you can get them off the machine, and then they can recover from their other illnesses. So those are the concerns about dead space. Right, so let us look at how we measure all these volumes. I mean, it's just give you a rough idea. You will be doing a practical later on this year, which will show you how some of the volumes are measured. But most of the respiratory volumes can be measured with simple spirometry. I'm going to show you what that means. The only volume that we can't measure with spirometry is the residual volume. The residual volume, you'll recall from yesterday's lecture, is that volume of air that cannot be removed from the lung. So spirometry can measure all the volumes that are in and out of the lungs. But residual volume, you need to do what is called the dye dilution method. We'll come to it. Or you can use more advanced methods, which are called body plethysmography. And finally, there is a method of measuring anatomical dead space called Fowler's method, which I will refer to briefly. So in previous times, and we have a model of this in the department, we used to use the floating spirometer, where you had a tank which floated in a canister, which floated in another canister, and it was full of air, and you could breathe into this canister. Yeah, and this canister was balanced so that the weight was in water was weightless, with a counterbalancing. So when you breathe in, the pen used to move upwards. When you breathe out, the pen moves downwards. And you can actually have a very calibrated graph paper, which then records all those volumes. These days, everything is done electronically. You breathe into an electronic spirometer, which gives you a printout or a readout, which you can simply download. And when you do that, you can actually measure tidal volume, you can measure expiratory reserve volume, you can measure inspiratory reserve volume, you can measure total this inspiratory capacity and vital capacity. All these you can measure. What you can't measure is the residual volume. You can only measure the dynamic volumes, not the static volume. We also use another tool, which is called the forced expiratory volume in 1 second and what is called the forced vital capacity. Forced expiratory volume in 1 second is that you ask someone to take a deep breath and blow out as much air as he can, and you measure it. And that in 1 second, a healthy person normally can blow out about almost 80% of his vital capacity. You compare that with the forced vital capacity, so that in the same reading, you tell the person to keep on blowing until he can not blow anymore, and you get forced vital capacity. If you recall that, vital capacity is maximum expiration. Either it is maximum expiration followed by maximum inspiration, or as in this case, it is maximum inspiration here followed by a maximum expiration. So you then get a ratio, the forced expiratory volume 1 over FVC ratio. In a healthy person, it is 80%. You can blow out with over 70 to 80% of your forced vital capacity in 1 second. And you find that that's the flow volume curve. This is the other way around. The previous one was shown this way. It doesn't change. And then in disease, this can change. If someone has form of an obstruction, such as bronchial asthma, you'll find that if this is normal, the normal person can't, his FEV1 ratio will become really low, and even his eventual FVC will be very low. So this is in obstructive lesions. Generally, you will learn in pathophysiology later on that there are obstructive lesions and restrictive lesions. Obstruction means an obstruction to flow. Restriction means a restriction in the volume. And you find that in people who are asthmatics, you get this type of a picture where the FEV1 FVC ratio is false. Restriction, you get the total forced vital capacity to be much lower. That's what you get. The forced vital capacity is very low. You can see that in someone who has obstruction, it takes longer, but you find the forced vital capacity is almost normal, yeah, near normal. But in someone who has restriction, the forced vital capacity is very low. And in fact, you might get a rise in the FEV1 FVC ratio, because it's a small volume, you can blow more of it out within 1 second. Yeah, and sometimes, of course, you get a mixed picture. No one expects you to memorize this stage, but start reading about FEV1 FVC ratio. What is it? It is in normal, and remember, in obstructive diseases, it is rises. In restrictive diseases, in obstructive it falls, and in restrictive diseases it may rise. Sometimes we even use exercise testing, where you find that person who is asthmatic, he may be quite, in normal person, you find that they doesn't change much, but there are some people who have exercise-induced asthma, and if there is a 10% drop in the FEV1 after exercising, you can assume that the person has a positive exercise provocational change, and that may be significant for some people who have exercise-induced asthma. But just remember one thing, that asthma is not, previously it was almost a stigmatized disease, because you could not treat it. People with asthma could not participate in normal, physical activity. Now, asthmatics, they're world champions. We have, I won't mention by name, but we actually had a Kenyan world champion who was asthmatic, and all he had to do was to take his inhalers, improve his lung function to normal, and he was actually a world record holder. Yeah, so they don't worry about asthma so much. It has to be managed. That's what's important. Right, now, how do we measure dead space? Dead space is done using some mathematics. It's called we use what is called Bohr's equation, which states that basically the tidal volume is the alveolar volume plus dead space, which is obvious. Yeah, that's what it is. We've already said that the alveolar, the dead space plus the actual volume reaching the alveoli make the total tidal volume. And by various experiments, it's been found that the amount of carbon dioxide expired is equal to the amount of carbon dioxide from the alveoli, that is from the alveolar air, and the amount of carbon dioxide from the dead space. Now you can imagine the amount of carbon dioxide from alveoli will be higher than the amount from the dead space, because dead space is atmospheric and it has very little carbon dioxide. But the alveoli will have, as we shall see when you do blood gas exchange, has 46 millimeters of mercury partial pressure of carbon dioxide, which is the same pressure which you have in venous blood. Once you know this equation, then the rest of it is simply you actually measure the amount of carbon dioxide, and there's a little bit of mathematics which you don't need to worry about, in which you can calculate the dead space. Those of you who are interested can go through it. It's really more for your information rather than for a mathematical derivation. So by using this equation, the Bohr equation, we can actually calculate dead space. Yeah, I don't want to go into the mathematics of it. It can also, anatomical dead space can also be measured using what is called the nitrogen, single oxygen breath nitrogen curve. That you have somebody who takes a single 100% oxygen breath, takes a big breath of pure oxygen and then exhales steadily. Then you can measure the nitrogen concentration, and you find that initially there's of course, nitrogen will come from the air in the lungs. Yeah, because if you have taken 100% oxygen, you have there's no nitrogen in it. So you find there are 3 or 4 phases of the nitrogen level that you get. Phase 1, yeah, where it is mainly coming out from the dead space, and then 2 is when it starts coming up from the main volume of air. And then you get the closing volume, which remember yesterday we mentioned about the where the small airways start closing, and it has been found that you can use this to calculate anatomical dead space as area under the curve in the phase 1, because that's the air coming only from the dead space. Yeah. So I again don't want to, we don't have to get into the maths of it. Just remember that this may be used. We have never done this in our labs, but it's more for our knowledge. Okay. It's good to know and good to study. You can go and look at the details of this phase 1, 2, 3, and 4. It's all in your textbooks, and it's also you can Google it. We can also do other tests to test for any provocational change in the breathing. For example, I already mentioned exercise, but we can expose people to allergens and see, like some people are sensitive to pollen, house dust, and that may actually affect their breathing if they're exposed. So we do a pre-exposure test, and then we do a post-exposure test, and we see whether there's any change. We can also use pharmacological bronchoconstrictive or bronchodilatory agents. In fact, tests, when we do what are called pulmonary function tests, we always do one without bronchodilators, and then one is done after giving the patient a puff of a bronchodilator, and you see whether there's a change. So you do both with provocation of allergens, but you can even use bronchoconstrictive or bronchodilatory agents and see whether the airway is actually hyperresponsive or not. All these are tests to see, to pick up patients who may have abnormal pulmonary function tests, which may indicate underlying disease, which I told you can be either obstructive or restrictive, in two broad categories. So all of the previous tests, the only volume that we have not been able to measure is your residual volume. So how do you measure residual volume? Well, you can, the two methods. There is the, let me just peep the next slide. Yeah. There's one in which a person sits in a sealed cabinet called a plethysmograph. And when you sit there and breathe through a machine that is analyzing your movements, and the pressure changes not only within the pipes that you're breathing in, but also within that cubicle. Those can be calculated to give the lung volumes, and it can also be calculated to give the hidden lung volume by some mathematical calculations, because you can measure actually the lung movements and pressure changes within the cabinet. What is important for us as clinicians is not the electronics and the maths of it, is that this can be used to give you functional residual capacity. There's another more straightforward method, which is the principle of dye dilution, that if we ever want to measure an unknown volume, like if we want to measure the total lung volume, how do we measure it? Well, you can measure it by the helium dilution method. You ask someone to breathe a little known volume of helium, small amount. You give it time for it to distribute, and you measure the new concentration. And the new concentration obviously will be diluted by the lung volume. So you can actually calculate the hidden volume. Once you have total lung volume and you have all the other volumes by which can the dynamic volumes, the hidden volume of residual volume can be calculated. Okay, so that is the dye dilution. In this case, helium dilution is being used to calculate an unknown volume. Right. So if you can measure total lung volume using the dye dilution method, then you'll be able to calculate the residual volume, because it will be either you can minus forced vital capacity from the total lung volume, or residual volume is also your the functional residual capacity minus the expiratory reserve volume. You can use any combination. Once you know the total lung volume, you can measure it. You can get the residual volume by minusing the active volumes, the not active but dynamic volumes. Okay. I think this we've already talked about. Let me leave this one out. Good. Right. In fact, we have, oh, I think these days somehow we are going faster. So, my friends, at the moment, what we have talked about are the various types of tools that we use to measure not only the dynamic volumes, but also the hidden volumes. And in those tools, we are talking about spirometry, the FEV1, FVC ratio, and we have also looked at the body plethysmography and the slightly indirect methods, the Fowler's method and the oxygen, single breath oxygen method, and also the helium dye dilution method. All of these are more for understanding. Nobody will take you to task and tell you to write an essay on helium dilution methods. So don't worry too much about this. So I think we can take questions. So let me start. What is VA? That's the volume which is in contact coming from the alveoli, and this is, the different books. This is tidal volume. Yeah. Okay. TV is tidal volume. Somebody has already answered it. If you take in pure oxygen, how do you release nitrogen? No, it's just one breath. See, when you take a breath, one breath of oxygen, suppose you are resting and you take a breath, there is nitrogen in your alveolar volume, isn't it? Remember, you can never remove your residual volume. So when you've taken oxygen, now as you breathe out, initially the oxygen that comes out will be from the anatomical dead space. Then it will start coming out from the functional residual capacity, and that's the one which will contain nitrogen. And that's why you get this graph, and then you get a second peak, because now you're getting air from the small airways that had the nitrogen which was not diluted by the oxygen. Yeah, I hope you understand that. No, it doesn't apply. Somebody has tried to answer it. No, that graph applies to oxygen, one breath. You're just taking one breath of, you're not breathing oxygen for many minutes. No, 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 no. Just one single breath of oxygen. Yeah. Especially dead space PE. Let me go back, then I will understand which this PE is this. No, no, no. That is the expiratory gases, the level partial pressure of carbon dioxide in the expiratory gases. Sorry for this. Yeah. I should have gone through. That I know you people love maths. I think that's why I told you don't worry too much about this. But this is the partial pressure of concentration or partial pressure of carbon dioxide in expired air. Okay, that's what PE stands for. Could you please explain FVC again? It's the forced vital capacity, that if you take as much air into your lungs as you can, now you are at the total lung volume, then you force all the air out of your lungs. That is called forced vital capacity. You could do it slowly, but you do it fast and you do it until you can't remove any more. That is your forced vital capacity, and that is used as a test of normality. And we use it in combination with the forced expiratory volume in 1 second. Where was that? Here. You see? So you are blowing out the air by force. And this is the other way around. So 0 is here and about 5 is there. So you're forced out, let's say 5 liters. Yeah. But in how much have you removed in 1 second? Normally this takes about maybe 2 seconds or maybe slightly less. So yeah, you can see here it's about 1 to maybe about 2.5 to 3 seconds. So what is the ratio of air that you've removed in 1 second vis-a-vis what you remove totally? That should be 80% in a healthy person. Emphysema is sometimes may give you a mixed picture, because as I told you, strict restriction is fibrosis. Like if someone has pulmonary fibrosis, there are certain exposures to certain chemicals can make your lungs exposed, and you get small lungs, so you'll blow out the air. Yeah. And in those patients, the FVC will be small, but their FEV1 would be big, so that they can release more of their volume in 1 second as a ratio. But in COPD and emphysema, that's why I don't want to go into too much, because then I would have to ask you, do you know what is emphysema? Emphysema is when there's a breakage of coalescing of alveoli. I'm saying in very simple terms, and you get larger cavities of air, but it may be accompanied with various amounts of fibrosis. So you may get a mixed picture in emphysema. Okay. In Fick's law, should one take account the molecular weight of the gas particles? That is taken care in the solubility coefficient. See, the solubility is related to size and related to properties of the gas. Like I told you, although carbon dioxide is a bigger molecule than oxygen per se, but it's more soluble. So it's not the pure size that matters in this case. It is the solubility coefficient. In Fick's law of diffusion, it is the solubility coefficient which is more important. I think this question I've answered already. Could you repeat what happens in restrictive and obstructive? Is changing tidal volume the most efficient way of changing alveolar volume or changing frequency of breathing? Yeah, this is a question that is often asked. To see, when we just see what your body does when you are exercising. Yeah, it does both. Yeah, so it's a combination of both. Now, if you make frequent small breaths, as animals do when they're panting, we don't pant. That is also used as a cooling device. When you're making frequent small breaths, that is more for cooling, although you may be able to get the same amount of air per minute, but you're also getting a cooling effect. Yeah, because especially a dog, for example, his sweating mechanisms are poor. Yeah, because they can't sweat. They score so much fire, the sweat doesn't dry immediately. So they use panting as a cooling mechanism. Yeah, but the body, when we need more air, uses a combination of increasing both the rate and depth of breathing. Yeah. Does intubation of weak respiratory help by reducing the anatomical days, or is only tracheotomy? We intubate. There are two ways of intubating patients, and you'll have lectures on this later on in your course. There's one tube which is put through the mouth and into the trachea. That is called an orotracheal tube. That doesn't reduce the dead space much. Yeah, it bypasses the nose, but it's not that significant. That tube is used to ventilate a patient when the patient can't breathe or there is obstruction. But there are some people who patients who have the orotracheal tube and they struggle. When you try to remove it, they can't cope. They can breathe for themselves with the tube, but the effort of breathing when the tube is removed is too much for them. It is those patients who are benefited by doing a tracheostomy. Between FEV1 and FVC, which volume is greater? Oh, come on, Mr. Raphael, isn't it clear? Forced expiratory volume in 1 second, of course, is smaller than FVC. Yeah. So as a ratio, it's about 0.8. As a percentage, it is 80%. Okay. Okay. So I think this is what I had to discuss. In fact, I think slightly more time has been allocated to me than was necessary. So what we'll do is, I will see, I'll discuss with my co-lecturer in this, and next week we might shuffle the lectures a bit to review. I think I'm done for today. Is there any other question? Okay, if there's no questions, so Ms. Chelsea, I'll then sign out, and then we will liaise next week and decide what happens during that time. Okay. Oh, sorry.